Okay, this term patient care, patient experience is pretty actually relatively new to the industry, so we should maybe start just by defining our terms. How do you think of that, Gaurdia?
So when I think about the patient experience, I think about, so I come from an acute care institution where we're taking care of really, really, really sick people. And so we want to have an experience for them when they come that they feel safe, that they feel heard, that they feel cared for, that they're going to have clinical outcomes that are going to be successful, or if not, they're going to be in a situation where their transition is going to be positive, where they're respected, heard, and cared for. So that's when I think about sort of in totality the patient experience, and also convenient, cost-effective, those kinds of things.
And in terms of meeting the need for a good patient experience, urgent care clinics have had a lot of success filling what was obviously a needed niche in the healthcare system. What is that? How do you think about that, Sharon? What is the niche that is being filled right now? Why did these need to become so popular so quickly?
So I think I can't speak to all of urgent care, I can speak to retail care. Sure. And what we're doing at MinuteClinic. So I think what we've looked at is identifying places where there are pain points in the system or patient needs that aren't being met, and trying to fill that gap. And so, for instance, convenience of office hours. 50% of our patients come into MinuteClinics in the evenings or after hours on the weekends. So that, I think, is a great example of filling a need that is important and valued by patients. And in doing that, in following that philosophy, that's how we've developed the MinuteClinic model.
Sorry, could you go a little further into the needs that are bringing patients in? There's the hours for sure. I know that a lot of care providers don't want to work beyond normal business hours, but what else is bringing people?
So the quality of care is table stakes. If we go beyond that and look at where patients have pain points in the system around primary care, around ambulatory care, we look at a few different things. So one, I think people define value differently. So cost of care. And creating transparency on the prices so that patients have, before they come in to receive care, an idea of the cost of care. So I think that would be another one. Receiving care when they wanted and when they needed. So every patient has a different perspective and different access points. So developing video consults and making that available to patients after hours or when it's most convenient for them. So those are some examples of self-serve, right? Allowing patients to be able to look at wait times, go online, schedule an appointment on their own, or hold their place in line. So I think those are some of the core tenets to retail health, and it's complementing the traditional healthcare system, but addressing those pain points from a consumer perspective.
Okay, and so then, Mike, with One Medical, you're kind of also creating a new model that is doing certainly more than what an urgent care would do, but less than what a MGH system would do. Can you tell us just briefly about that model and what niche it's filling in terms of patient experience?
Yeah, so most people, especially in Boston, aren't really familiar with One Medical. They're like, what's this medical one thing? So I'm not sure if many people feel this way here, but One Medical is actually the largest independently owned primary care group in the country. So we have offices in several different major cities. So what we're doing differently is really reinventing the primary care experience based on what the patient needs. So what does that mean? Think about how you book for an appointment. Do you call, then you wait, you meet with someone, they try to figure out where you meet in the schedule? Why can't you do it on an app? So we have in-house engineers that designed our app so people can access us at any time. They can book their own appointments. If they want to meet with a virtual provider, we have a whole virtual medicine team that caters to them. So we're trying to meet patients where they are and how they want to integrate with care.
And so Gaurdia, I'm wondering how MGH and an institution is having to change because of new people disrupting the system. Something like MGH has been around for a very long time and didn't have to think about something like the patient experience so much because they weren't being challenged.
So I would disagree with that a little bit. So,
Please.
Mass General's been around since 1811. So over 200 years, and I think that it's always been an organization that's always been innovating based on the environment that it's in. And so when I hear my colleagues talk, one of the things that I'm struck by when we're talking about the patient experience is that we're getting ready to open or build a new building that's going to be opening in 2026. What I'm struck by is the fact that we are very interested and are now doing leveraging technology. So when we're talking about virtual visits, virtual health, ways to schedule appointments, all those kinds of things, as we're looking at that new building, we are going to be leveraging the best that technology has to offer. But at the same time, when we have our researchers and our engineers and our clinicians and our scientists and everyone that are in the room, one of the things that we want to make sure is that one of the things that created Mass General is that it was a hospital for the poor and for the poor and underserved in the Boston community. So there's a component of making sure that we're going to continue to offer a healing environment. And what does that mean for our patients and families? So you can have the best technology and all of those kinds of things that go along with it, but you have to have that clinician-patient experience that they feel safe, listened to, heard. Their wishes are put first. How do we work around with not only themselves, but their family members?
Yeah. And this seems like kind of a common thread that I'm hearing between the three of you, that we need to hear people, we need to deliver care where they are on the terms that they're looking for, and yet the need for that to exist clearly means we're not doing it well right now. Where are we failing as a system?
I think the biggest way we're failing is just access. The way we see or have primary care providers, our patients can't really interact with them the way that they want to. So it's either having availability or nowadays just the technology to interact. So we have a lot of different telemedicine services. So I'll have a lot of younger patients, say 20-year-olds, they're seeing me for more urgent things because young people are just immortal. They can do anything, they can conquer everything. The biggest thing that's gonna face them is a cold. So a lot of times they'll contact us through our telemedicine services. This is very different from, say, some of my older patients. If I have a 70-year-old man, he's not using our telemedicine service to help with his cancer diagnosis. He's gonna instead message me, and I'm gonna do this old-fashioned thing and give him a call and actually connect with him and say, why don't you come in, we can talk about this more. So it's not enough just having that technology available, it's being able to integrate it in the primary care setting and having that longitudinal care, because that's what matters. We're there with them, not at that moment, but every single day.
Yeah. I think the cost of care is also a challenge for consumers, based on the way healthcare is being, health insurance is being laid out. A lot of consumers are being consumers and thinking about where they receive their care, when they receive the care, and how it relates to their patient responsibility. So to me, that between access and cost of care, put those two together, and I think that's currently where we have a lot of challenges for our patients.
Yeah. And I think one of the challenges that we're facing right now is this consumer-driven culture of technology. So you might be seeing a lot of advertisements for mail-ordered prescriptions. Mm-hmm. So from a primary care standpoint, that is my biggest fear, because I'm having patients interact with these independent providers. So for example, sexually transmitted disease testing. Mm-hmm. They're going to mail out their lab tests to an outside group who's going to give them a diagnosis and say, okay, go follow up with your PCP, or here's some prescriptions. Not really taking the time to say, deal with the mental anguish that some of these sexually transmitted diseases can focus on. Mm-hmm. So imagine being diagnosed through HIV through a mail-ordered system. How is that interaction? All the kind of emotions with that diagnosis. Mm-hmm. So that's why it's very important as we utilize telemedicine, it's grounded in primary care, so we can actually connect with that person beyond just their diagnosis.
Mm-hmm. So speaking of connection, long-term relationships, continuity of care is a goal of primary care traditionally. Is there a tension there with ways MinuteClinic is thinking about treating patients versus the way One Medical is thinking about continuity?
So one of the key pillars to MinuteClinic that I think was the second thing we worked on. The first was the quality of care. The second was the connectivity. Acknowledging that that was an important part of not adding to fragmentation in care, and developing the connectivity, if you will. So at the end of a visit with patient permission, the end of visit summary is always sent on electronically or by fax if need be, through the Epic platform or other HIEs, or fax to the provider. So I think that doesn't answer all the questions, but that is important to our patients, and that is obviously important to the primary care providers and the medical home that they belong to.
Yeah, and
You can add to that.
yeah, a big thing for family medicine providers is that we don't want to lose that relationship. So it's one thing to say if you have someone with diabetes, you're checking their blood sugar and hemoglobin A1C. If you actually look at the data, the blood sugar is probably one of the least important things in decreasing mortality for diabetic patients. I say that with a qualifier, in that if it's crazy high, then yes, we need to bring your blood sugar down. But it's other things that are important. It's different social determinants in figuring out where do they live? Do they have access to healthy foods, healthy environments? Are they exposed to smoke? And in doing so, as a primary care provider, I can kind of figure out where they live and tailor their health goals to their needs. So I'm not adding a medication. I'm saying, hey, can we get you out of this environment? What can we do to change the environment that you live in so that the healthy choice is the default choice?
And so I think focusing on changing environments and social determinants is something that we've heard about a fair amount today, and we keep hearing about, and a lot of providers want to do, and yet don't have the time or don't have the compensation reimbursement system is not such that we can really focus resources on that. But you feel like, you told me at One Medical you feel like you do have time to do that. What are you doing differently there that gives you that time? Because I think a lot of primary care people want that.
Yeah, so it's pretty fantastic because I get a lot of time with patients. We're able to do that because of the model we have set up. Essentially, we don't have medical assistants, so that means that we are able to save a lot on overhead, so we can extend our appointment times. So instead of a 10 or 15-minute physical, I have 40 minutes. That's a lot of time to get to know people. And so, for example, I'll work with a lot of high-functioning people, high-power lawyers, consultants, you name it. And I ask them what they do. They focus on their work. I was like, okay, what do you do outside of work? And what I like to do, especially if I have that time, is what do you like to do for fun? Talking about joy. What makes you happy? Because the absence of disease isn't healthiness. So I'm trying to improve their overall health. And a lot of times that piece is missing. So I can kind of work with them, figure out what's important to them, and not only make them disease-free, but also happy and healthy.
All right, we'll go to audience questions. I just want to wrap around one more thing. So by cutting out sort of staff that might be seen as, I don't know, as ancillary staff or office staff, you're doing a lot yourself as a physician, and many people have argued that the model is to offer, to expand and have more people helping out a physician so they can see more people and do more with their time. So it sounds interesting that you're challenging that idea with One Medical. But I know, Gaurdia, as a nurse advocate, that would seem to push against that we need to have nurses play a bigger role in inpatient care and not have physicians trying to do everything.
Well,
Yeah.
I don't know that it has to be an either-or scenario. I think that there's certainly the expertise that physicians and all different kinds of clinicians bring and including nurses. So I think it's really a partnership. I think nurses have always looked at patients holistically for many, many years. So we've always thought about the psychosocial, biopsychosocial, spiritual aspects of care. We continue continue to do that to this day. So I don't necessarily hear you saying eliminate nurses. That was not my sort of perception of the conversation. I think the perception is that we have to have the right clinicians at the right time for the right patient need. And so whatever the scope of practice that that particular individual possesses, we need to make sure that our patients interface with that person, that it makes sense from a cost-effective perspective and also their area of expertise. That's what I heard you say.
And I 100% agree. That's the one thing you learn in medical school. Always respect your nurses. They will save your life. And that's right.
Yeah.
In our model, and this is just one model, and kind of getting to the question of that's going to come up of how do we create these new models. This is just one way of doing it. So we do have RN nurses as well, but they're part of our virtual team. They're the ones going through all the different lab results, making sure there's nothing urgent. And if there is something urgent, they've already taken care of it before I've arrived. So that's just changing the role and adapting it to our style of primary care. And that's also going to be very different how a nurse's role is in a hospital. So there's many different ways to take this, different staff members, but it's a matter of having everyone rise to the top of their level and finding their best role in an organization to improve health outcomes.
Mm-hmm.
See, I'm trying to draw the contrast between you, and you keep just agreeing with each other.
Well, I think that just means we're both aligned on improving the patient experience.
Okay. Yeah, so that's the question we have, which is anonymous, not ideal. If you can give your name and organization, that will help us to know that your question is real. But either of you want to chime in on how do we bring new primary care models like One Medical to poor and underserved populations?
So I can try to field that one.
Continue.
But so when One Medical was designed, it mostly looked at private insurers because they were trying to figure out how do you make this model work. And as we've grown, what we've actually done is partner with different enterprise groups. So this is different businesses who their goal is to keep their employees healthy. And that could be a major organization. Unfortunately, I can't figure out which ones are ones I can say or can't say. So we'll just say there's big organizations out there, many of which are in Boston, to small rural organizations. So at one moment, I could be taking care of a CEO of a company to one of the janitors. So that's our way of kind of reaching out to underserved populations, but that's just where we are right now. I'm really excited to see where we're going to go as an organization and try to really work with the underserved because that's what's most passionate for me.
So from a MinuteClinic perspective, I think one of our key tenets is being local, providing care in the communities where people live, making sure that we are part of all the different insurance plans, including the Medicaid programs, and then keeping the cost of care at the lowest level possible, which is a walk-in level of care versus an urgent care and an emergency level of care. So those are some of the aspects of how we bring the care to different, both underserved populations and populations that are of a lower socioeconomic status.
Excellent. Thank you. And a final question from Julia Sklar. Tech moves quickly and institutions tend to move slowly, so how is MGH navigating the planning of tech/innovation now for a building that's not opening till 2026?
So that's a really good question because, part of as we're talking about the design of this building and thinking about the history of Mass General, that we know even as it opens in 2026, that we have to sort of anticipate what the future is going to be in regard to technology and innovation. So I feel like we have sitting at the table, which is actually a wonderful thing to see. We have our innovation expertise team that's sitting there. We have our scientists that are there. We have our clinicians that are there. And by the way, something I actually forgot to mention about the patient experience is involving the patient. And involving the family. We didn't say that up front. It's like, oh yeah, I got to make sure I say that. And so we have all of the key stakeholders sitting at the table, but you're absolutely right. It's very difficult to anticipate what the next 10 or 20 years are going to look like, but we're trying to do our best by doing that and sort of seeing what we can do and knowing that it's not going to be perfect.
Well, best of luck to you all. Thank you for the questions. Thank you to the guests.
Thank you.